Good afternoon, ladies and gentlemen. Thank you for joining us in this webinar. I'm Lily Shah, Professor of Nursing at Flinders University, Australia. Can you please use the chat box to introduce your name and the organization you are associated with? Thank you. This webinar is the second part of knowledge exchange activities in a project titled Strengthening Professional Collaboration in Dementia Caregiver Education and Research while Prevention and Evaluation of the Eye Support Program in Australia and Greater China. This project is funded by the National Foundation for Australia-China Relations, Australian government. Flinders University is the leading organization. We are very proud to work with our partners in Australia and China. Those partners are University of New South Wales, National Aging Research Institute, University of Wollongong, Peking University, Xi'an Jiaotong University, Taipei Medical University, the Chinese University of Hong Kong, and the Kaibu Nursing College of Macau. I'm very pleased to introduce today's presenter, Professor Bianca Brejnev. Next slide, Bianca. Professor Brejnev is trained in medical anthropology and public health, and her research expertise is in cultural diversity, dementia, and mental health. In the past 15 years, she has undertaken several studies that explored mental health and culture, mental health and the life course, and dementia and cultural diversity. She has authored over 100 publications, including a sole-authored book, Moving Picture, Unforgotten, Love and Culture of the Dementia Care in India. She's the lead investigator for the Moving Picture study in Australia and India. In recognition of her research, she was awarded the Victoria Young Tall Poppy Award in 2018. Please join me to warmly welcome Professor Bianca Brejnev. Over to you, Bianca.
Thank you so much for that very kind introduction, Lily. And thank you to all the participants who are joining both from within Australia and across China and other parts of the world. It's my great honor to be here today. I will be talking to you about culturally appropriate care for culturally diverse people with dementia and their carers in Australia. But many of the lessons that I will share with you today would apply to populations that live across the world. And I have tailored my discussion to focus on Chinese families, both in China and as part of the diaspora. The objectives of today are how to negotiate different understandings of care, how to communicate with culturally diverse families about dementia, and what to do when cultural conflict arises, as it inevitably does in some situations. I begin by discussing what is culture, and the first part of my presentation will go a bit quickly. Now, culture reflects the norms and values of a given society and the people who are part of it, and it is the way we view the world. Culture is not static, it changes over time. It changes as a result of migration, globalization, socioeconomic development, and other factors. Now, culture is a bit like an iceberg. And this is a very famous quote from a sociologist in the UK, who said that culture hides much more than it reveals. And strangely enough, it hides most effectively from its participants. This means that many of our values and our beliefs around culture are often hidden from us ourselves. We take this as the natural way of the world and the way things ought to be done in our families and in our communities. This is very important when it comes to dementia and care, because how we look upon older people, how we think about family members, particularly older family members, and what we think of illnesses and conditions such as dementia will shape how we approach it and how we approach people who live with dementia. Now, in Australia, it is a multicultural society, and it is also an aging society. By 2056, about 8.5 million people in Australia will be over 65. This may seem like quite small numbers to people who live in China and other parts of Asia. However, that's quite a big proportion of the Australian population. It will be almost 20% of the overall population. But the growth in the 65 cohort won't be as fast as it once was. It does slow down, as you can see from this graph. But what I would really like to draw your attention to is all the different colors in the graph. It signifies that, in fact, some of the largest growth is happening in our immigrant populations, including our Southern and East Asian born populations, which includes the Chinese communities around the world. What this means for dementia services is that we are servicing increasingly diverse communities. CALD, or culturally and linguistically diverse, is a term that we use in Australia to refer to different ethnic minority communities. What it also means for services is that there will be major local variations across the country in terms of which immigrant communities they will be servicing. And that this service profile, these cohorts, will vary by immigration history. For example, we might have had Chinese communities that came to Australia over 200 years ago, and since as part of initially the gold rush, and they settled in Australia as labor. More recently, they might have come as students, and then even more recently than that, as economic migrants from places such as Hong Kong, Singapore, Malaysia, and China itself. So the immigration history will shape how people experience life in Australia, as well as experience illness, such as dementia in Australia. Their illness experience will also be influenced by their age, their gender, their religious beliefs, the amount of education they've had, and the job that they do. Now, all of these things are going to feed into different understandings of care. And here I'll spend a little bit more time because this is our first objective. First of all, I'd like to draw your attention to the fact that we know certain ethnic communities have higher risk of having dementia. This is because these communities are often more socio-economically disadvantaged. They might have had less education overall. They can tend to be isolated from other parts of the community, sometimes because of low English proficiency. They also have a higher risk of heart disease and hypertension and diabetes, both due to genetic factors as well as diet and lifestyle. And they also might be more prone to certain other modifiable risk factors such as smoking and alcohol consumption. Ethnicity and dementia are also interconnected by the factors that affect timely diagnosis and care, including the interpretation of symptoms, language barriers, knowing where to go and seek help, particularly if you have low English proficiency, and lack of culturally appropriate assessment tools. For example, the mini mental state exam is often used to screen and identify for dementia, although we know that it is not a culturally fair tool, and that in fact it is better to use tools such as the RUDAS, the Rural and Universal Dementia Screening Assessment. Other factors will also affect timely diagnosis and care, and these include people's knowledge of dementia itself, as well as the health system that they're working and living within. Do they go to a doctor as a first port of call? Do they know what a neurologist does? Do you know what a neuropsychologist does? How do the nurse viewed in this arrangement? How are care workers viewed in this arrangement? Cultural patterns of care and caring in families are also very important with regards to timely diagnosis and care. In many Asian communities, there is a conception that care should occur within the home and within the family. We should not take our problems outside and share it with others. Stigma is an important belief as well that may deter timely help seeking, particularly if certain symptoms of dementia, such as disinhibition or aggression, might be interpreted as a sign of madness. And there is also denial and dismissal from care providers that we know from the literature, particularly, unfortunately, amongst GPs or general practitioners or family physicians, where they might say, well, this is the normal sign of aging, don't worry about it, it's all fine. Here is an example of how dementia might be described in simplified Chinese or Mandarin. I will not attempt to pronounce any of the Chinese words. Lily, you are welcome to jump in and have a turn if you like. You're on mute, Lily.
Yes, I'm very happy to help you. Which one would you like?
We might, maybe if you could do the second one.
The second column, or the second one of the Chinese?
The second row, yes.
Yeah. The second row?
Yeah.
The pronunciation of those?
Yeah, yeah.
Okay, yeah, for the description of the dementia, 中文有不同的中文的描述，对痴呆症，比如说老年痴呆症、脑退化症、失智症，或者是脑潮懂这种不同的说法。Thank you, Bianca.
Thank you, Lily. So as you can see, many of the words that we use to describe dementia in Mandarin are not always the most appropriate words. These words can be very confronting for families. I know some of the terms we've got here are colloquial or informal, but nevertheless, they can be frightening for a family member to think that an older relative is now experiencing these conditions, and this terminology itself might frighten them and discourage them from going to see the doctor. However, I want you to please keep these words in your mind, because I will come back to them shortly, because I want to make another point about dementia and how we think about it. So just keep this in the back of your mind. What I would like to draw your attention to now is that when we have disparities in dementia risk, in dementia diagnosis, and in care, what ends up happening is you can end up with big differences amongst different communities with regards to referral to specialists, with regards to both the prescription and the use of anti-dementia medication. We can end up with delayed diagnosis. We can end up with discontinuing of medication because people don't understand why they're taking it and why they're experiencing the side effects. And it's encouraged you experience difficulty in finding culturally relevant aged care services. All of these things combined can work to make the lives of people living with dementia from ethnic minorities or culturally diverse communities very difficult and reduce their quality of life. However, remember that slide I asked you to keep in mind about how we describe these terms? I would now like to draw your attention to how care is described in Mandarin. And if you just look at the terms that I used, closed bosom, shine and watch over, watch and protect and manage, love for a dependent. The point I would like to make here is just because in some of our communities, we do not have an understanding of what dementia is, does not mean we do not know how to show respect for older people, and we do not know how to care for older people. These are beautiful terms that are used in the Chinese language. And I think they illustrate very much the dependent relationships that exist within families and the notion of how older people should be cared for. So I wanted to just make that very important point. Now, more broadly, in culturally diverse families, dementia care. There is a cultural expectation that care should occur by the family, that it often occurs in an intergenerational household or in multi-generational living. Quite often women, especially daughter-in-laws, most often are expected to do a lot of the work. Outside help is often seen as inappropriate and seen as a shame on the family if they encourage people to come from the outside to help them. And having a family member admitted into residential aged care is often seen as very stigmatized and a place of where one is abandoning or dumping a relative. So these are very common conceptions that we will find in our work with culturally diverse groups. Often, unfortunately, health and care providers have very limited awareness of some of these barriers. And sometimes, as I mentioned earlier, there's a tendency amongst some to dismiss dementia symptoms as normal aging. We have certainly observed this amongst general practitioners. There's also systemic barriers because there is in the Australian setting a shortage of residential and community-based ethno-specific services. And people are often very reluctant to go into aged care services where they may not speak English and where there may be few people who speak their own language. It actually further amplifies their isolation and worsens their dementia. There are limited availability of culturally adapted resources and bilingual staff, and therefore people struggle to access information in their language in an appropriate, that is pitched to an appropriate level for them. There are also long waiting lists associated with accessing ethno-specific care. And visa and citizenship status in Australia can certainly impede older people's access to many aged care services, particularly if you are a new arrival or you have not come on a family dependent visa or something such as that, because then quite often you're not allowed to access the Australian health and aged care system unless you're prepared to pay for it as a private citizen, and that can become very, very expensive. Certainly amongst the Indian community, for example, we have heard cases of older people who have developed dementia, but their families have actually opted to relocate them back in India, where they're able to afford to have nursing staff come and present at their home 24 hours a day to care for them. So different kinds of challenges. Now, the consequences, of course, of all of this is that ultimately the stress and the burden amongst family members and workers is amplified. And it can leave them feeling very burnt out and very depressed, and they can often have their physical and their mental health suffers. It also increases the risk of elder abuse. We know this, where the older person themselves is likely to be neglected or to be physically abused, to be hit, or to be psychologically abused because the carer themselves is just so tired and exhausted from doing this work. Overall, there may be a decrease in the quality of care and an increase in the socioeconomic disadvantage that the family is encountering. Very often we know when women take on this work, they might cut back on their paid work, and that means that they have less resources in later life to see them through their own retirement and aged care journey. However, there are things that can be done, and it's very important that we encourage families and services, especially culturally diverse ones, to avail of what is available. To do this, we actually produced films where we worked with carers from various communities about how we might encourage that. So I will now share with you one of the films. This is one we did with Mandarin-speaking carers across Australia. Now, in the event that you cannot see the film in a good quality through what I'm sharing, Carolyn will also put the link into the chat, and you can access it through there and watch it directly online. It is only about 5 minutes at the very most, but let's give it a go and try it.
第一呢，要先把自己用这些知识把自己武装起来，也就是说，你要知道你在对待在你面前你的敌人是一个什么样子的。这个 dementia 这个 monster 这个魔鬼，我们叫中文叫魔鬼，在你面前是一个什么样的一个魔鬼。然后呢，你要有非常强壮的身体。 非常强壮的身体，才能够让你能够度过下几年的时间。这是第一。第二个就是说，强壮身体还包括你不可以得病。
改变是很大的，因为看到我的母亲的这种，她自己的恐惧，还有她的无助，那么我们对母亲的这种感情。 实际上是更加深了，就是很想去帮他。
If the patient has got dementia, you have to be aware and you have to adapt to the diagnosis. And and you have to change yourself.
是这样子，因为有的时候生活也其实对我来讲也比较纠结的是什么呢？因为我母亲现在就是得这种病，然后她也80多了，然后我下面呢还有一个女儿，她才11岁，所以有的时候呢我需要照顾母亲，又需要照顾女儿嘛。
因为你要全心全意的来做这个照顾的病人呢，这个方案每一天从还没有睁开眼睛就要想这一天怎么样过。
So sometimes we need to let the family member know, okay, even though you would like to look after your parents, but also you need to look after yourself. Otherwise, if you get sick, so no one can look after them and no one can look after you.
在 CALD support group 呢，我们大家都有同样的情况，我们就会大家坐在那里说一说我们这些 frustration， 就是说大家互相交流一下，你是怎么样面对这个问题的？如果他晚年不睡觉，或者是在太阳落山的时候，他会特别 agitated， 你怎么办？那我有什么办法？他有什么办法？大家互相交流，然后 coordinator 会给我们呢，拿来不同的 program。然后呢，带我们出去活动一下。
I think the most important thing is to let people from the CALD communities know that there is nothing wrong with people with dementia condition. We need to be receptive of them, accepting them, and embrace them. By embracing them, the whole community is behind them. Family, they will know that they don't have to scare. Because we will be supporting them behind.
照顾脑退化症患者，在体力上和精神上都是十分困难的。如果您不能好好的照顾您自己，您就不能很好的照顾您的家人。所以一定要学会放松，哪怕是短短的几个小时，都会十分之有帮助的。同时呢，也要知道怎么样去寻求帮助。您可以跟您的家人和朋友去聊一聊。也可以跟您的家庭医生谈一谈，同时呢，你也可以登录 Dementia Australia 的网站去寻求更多的资讯。最后呢，你还可以向当地的市政厅去寻求帮助。
Okay, I hope you enjoyed that and it was valuable for you and you could see to a good quality. The website at the end, movingpictures.org.au, has a few other films in there, in Mandarin as well as in Cantonese. And we have also got some comics in Mandarin and Cantonese. If you would like to access them and use them, please feel free to do so. They are for free and are intended to help the community. I would now like to move the discussion along to talk about how we might communicate with culturally diverse families about dementia. Let me start by talking about cultural competence. This is a very difficult term. There are varying definitions around it, and people often struggle to understand what it means. We did some research in this space, and what we understand it to mean is that in order to do this work well, to communicate with culturally diverse groups, and to do it effectively and meaningfully, you need three critical ingredients. The first thing you need is personal motivation. Your staff must be committed and passionate about working in this space. They may be from the same cultural group, they may speak the same language, they might have been exposed to different ethnic communities growing up, or traveled and worked in such spaces. These are all important personal sources of motivation. Second, you need to be professionally resilient to do this kind of work. When you work with culturally diverse families, often you are exposed to various stories. Some of these stories can be very difficult to listen to. They might be stories of trauma or abuse, of struggle and stigma. You need to be very strong in yourself mentally to cope with that. What will assist you in that process is having good organizational support. Organizations that value diversity, that support the use of interpreters, and that seek to create networks with other local services. So they recognize that they're not the expert at everything, but they want to bring in that support and work collaboratively, often do it very well. And those are some of the critical ingredients to delivering culturally competent care. I would like to also reassure you, because I get asked this question a lot, how much does cultural matching matter? That is, if I'm not a Chinese-speaking person, can I work with a Chinese-speaking person? And the short answer is yes, of course you can. We have done research in this space, and we have found that no socio-demographic or cultural factors are found to influence what is a positive patient-provider relationship. This does not matter that much to patients. What really matters to them is continuity of care, rapport, feeling listened to, and a mutual understanding between the healthcare professional and the patient. In other words, create a relationship with them and sustain that relationship with them to meet their needs. This is not always easy for service providers, and I'm going to give you a few tips now about how you might work with families when you do and when you don't have an interpreter. So let's talk about what happens overall, whether you do or don't have an interpreter. First of all, it's very important to take a person-centered approach to understand what the family needs and what the person with dementia needs. It's important to reciprocate. People are telling you about their struggles and their hardships, about what works and what doesn't work for them. Sometimes sharing a little bit of yourself, whatever you are comfortable with, is important to build that relationship. It cannot only be a one-way street. Sharing information a little bit about yourself also helps to build mutual respect. That it can also be created through nonverbal communication. It's very difficult in the era of Zoom to communicate effectively, but we use our bodies a lot in how we talk. Holding hands, silence, a sympathetic face, nodding, all of these things help to communicate effectively our care and our attention that we give to families and people with dementia. Objects are very important ways also to create that care, as well as the physical environment. Should not be too noisy or in a very busy space. You might want to use a calm place, a quiet place where you can effectively talk to each other and concentrate on each other. A little joke, what I have found consistently works very well, no matter which culture I have worked with, is drinking tea. Let me give you a little story about this. I'm from India, and I did my PhD on dementia care in India. Now, when I used to go to families' homes to talk to people with dementia, the family would always say to me, Bianca, would you like a cup of tea? Now, I have to tell you, I really don't like tea. I can't stand it. However, I realized if I could spend 15 minutes arguing about how I didn't really need to drink tea and I had a glass of water and it was all fine and I don't want to inconvenience everybody, I would waste a lot of time. On the other hand, if I just said, yes, I would love a cup of tea, please give me whatever cup of tea you'd like to give me, it immediately started a conversation. And it was much easier to establish a relationship. So it sounds very simple, and I know it's harder in the age of COVID, but if you can, drink the tea. It makes a very big difference. Now, when you are working with an interpreter, it's a few things to keep in mind as a healthcare worker. First of all, always direct the conversation to the client, not to the interpreter. Try and use non-technical language, short sentences, very simple, and allow the interpreter time to relay what you have just said. At the end of the assessment, make sure you summarize the key points and make sure the client, in this case the family most often, is clear on any issues that need following up. Never use family members as interpreters. This is a big no-no. Quite often what will happen when you use family members as interpreters is they will filter the information. They will not tell the person with dementia what they really need to know or what they ought to be doing. They might tell them what they think they need to know. Their family wants to protect them. They might hide information because they want to help keep the positive feelings in the person with dementia, or they want to protect them from bad news. In Australia, we are very clear about our rules and our laws that we must tell people all the information that is relevant to them so they can make an informed decision. And this is why we recommend the use of interpreters. It's important to be in Australia, in our healthcare system, with our communication, we value honesty and trust. And we think that it's important to use interpreters to create that honesty and trust between the providers and the patients. Quite often, there may also be a power dynamic within the family, and there might be deliberate and sometimes unfortunate reasons why family members may not want to let the person with dementia know what's happening. So it's important to also be aware of those internal dynamics and conflicts that may exist. And this is why we recommend the use of interpreter. Now, I hope this information has been useful for you, but at some point or the other, cultural conflict will happen. You're not going to have a harmonious relationship with every family in every instance all the time. There will be tension. In Australia, when we look at the common causes of complaint in residential aged care, we find that it's often insufficient staff. There's errors around medication administration and management. There's quite often concerns about the personal and oral hygiene of the older person, of the resident. Quite often the family member or the person themselves may feel that it's not been adequately tended to. There's concerns around what's been done to mitigate falls, and often in the event of a fall, how that's being managed. And there's complaints about the lack of consultation and communication. When we look at what creates conflict in community-based settings, again, it's a lack of communication or consultation. People feel like they're not being heard or listened to. There are always complaints about fees and charges, that's not being clearly communicated as well. That people feel like they're paying for something they're not receiving, or paying too much and not receiving enough. There's issues about consistent client care and coordination, often being inconsistent, and worries around not having that continuity of care, about how finances are managed and how money has been reimbursed. So there's a lot of issues here around financial management as well. One of the things that we don't talk about enough, though, and this is very unfortunate, but Australia's aged care workforce is extremely multicultural, right? And it's growing increasingly diverse. Over 40% of Australia's aged care workforce is already made up of people who were born overseas, mainly from places such as India, the Philippines, and increasingly from African countries such as Nigeria. Now, it's very important for the aged care workforce to be aware and knowledgeable about dementia and how to care appropriately. However, you have to understand that just as your families come from ethnically diverse backgrounds where they may have never heard of this word dementia and may not be aware of it, so too are these workers from those same backgrounds. They also might struggle. And therefore, we have to, in our efforts, look at increasing awareness and reducing stigma, both in terms of the workforce as well as the community itself. And in doing so, we will assist people with dementia to be socially connected to their communities and to improve their quality of care. However, as I mentioned earlier on, there is some very unfortunate aspect that is very rarely talked about, I think is very important to talk about. And this is about racism and discrimination. Migrant aged care workers often face very prejudicial treatments from people with dementia and their families. They may experience racism and discrimination on the basis of their skin color, on the fact that they have a very heavily accented English, or they may not speak English very well, or that their approach to care is very different to perhaps how other communities perceive care. For example, in some communities, it may be acceptable for an aged care worker, whether they're a man or a woman, to help an older person take a shower. In other communities, it may be extremely inappropriate if an aged care worker who is a woman tries to help an older man shower, or vice versa. So we have to be aware that these issues can sometimes come up. Now, services can try their best to accommodate the family's needs and requirements, but this isn't always possible. And therefore, these tensions can often arise. The sector also faces major challenges, and there's very high turnover rates and staff shortages in aged care. And therefore, what's happening is the proportion of inexperienced staff is increasing. Because of turnover, there's also there's not a lot of continuity of care. You don't seem to get the same aged care staff member all the time. They're sort of coming and going quite often, and that can increase the relationship, the distress that residents might experience because these relationships are constantly disrupted and have to be restarted. It also increases the cost associated with recruiting and training new staff and reduces the overall quality of care. So I would say to you that if you are in a recruitment role or in a leadership role where you have the opportunity to, I guess, train your staff in providing dementia care, then it's also very important to focus on ensuring that you create a culturally safe environment for those workers to minimize the risk of discrimination and racism in order to keep them on and keep them going and give them meaningful work as well. Similar to the consequences of what happened within families, likewise, when you have conflict between aged care workers and older people, including people with dementia, there is a greater risk of abuse, of physical, psychological, and sexual abuse. Certainly, the Royal Commission into Aged Care Quality and Safety in Australia estimates as many as 30% of Australia's aged care residents have experienced abuse. There's inappropriate use of restraints, there's unreported assaults, particularly on older women, and people being left in extreme pain at the end of life because they don't have access to appropriate pain relief and palliative care. So these are some of the things that can actually happen when you have cultural conflict, because the most simple solution that staff employ when they have cultural conflict and they feel that they are being discriminated against is they minimize the time they spend with the older person and they withdraw as much as they possibly can. Most of the time, what will happen is people will go into look after the older person, but they won't necessarily speak to them or engage with them, or they might hurt them because they themselves are in that conflict. So we really don't want to create that tension between workers and older people. Rather, we want to create a positive and harmonious relationship to avoid all of these terrible consequences that arise from it. Now, how do you resolve cultural conflict? The first thing we found in our evidence review is that actually friendship and a familiar-like relationship is very important. Terminology matters a lot, right? So whether you choose to call a person sir or ma'am or uncle or auntie or mother or father or whatever the terms that you might use, that creates those sort of familiar-like relationships, right? That someone is like your daughter or your son or your mother or your grandmother. Those networks or those bonds help to create respect. The second thing that can help resolve cultural conflict is focusing very much on the perception of care work, both by migrant care workers as well as the local care staff, where this sort of work should be seen as work that you do to look after older people. It's valued, it's important. It's an opportunity to care for someone. I know in places such as in China and in Asian societies, we value filial piety. These are the sorts of ideas we should be playing with to create that reciprocity and mutual respect between the communities, between workers, between families and older people themselves. And finally, availability of organization support for languages and professional development. All of these things go a long way to creating respect. I'm almost at the end of my talk now, so I want to just bring it back to a few key points to reiterate a few things. First of all, is Australia's older population is very culturally diverse, so we're both an aging and a multicultural nation. It's important to consider cultural factors when we're working with people living with dementia, how symptoms are perceived, how care is understood, where it should be delivered, what stigma might shape the journey, and what services people might actually need. Right? We need to be open to learning from different communities as well as providing services and education to them. Remember the beginning when I showed you the slide in Mandarin about how dementia might be described? But then also remember how I showed you the slide about how care might be described, right? So you can have these two things occurring at once. The dementia might be treated as a sort of stigmatized condition, but care is also something that is revered and valued in societies. So we need to actually learn from communities. It's not a one-way street, as I've said before. I think we must involve target communities in every stage of the discussions and services in education. This is a person-centered approach. Communication is key, particularly creating that kind of reciprocity and mutual respect. Remember, you've got to give in order to receive. And so that's really quite integral. And beware of cultural factors, understandings, and perceptions that can shape how people approach you. People might have inherent racist beliefs or discriminate against you on the basis of your skin color or the accent you have or your proficiency, etc. There are ways to overcome it. At its most simple level, drink the tea. That is a really important way to help create relationships and rapport building and create that continuity. I've shown you a quick film from the project I lead called Moving Pictures. That's where the resources are. That's what some of them look like. They're all available for free again. And I will stop there now. And if there's an opportunity for me to answer any questions that people might have, I'm happy to do so. Thanks, Lily. Back to you. You're on mute, Lily.
Okay, great. Thank you, Bianca, for your very informative presentation. Thank you for making the very complex issues, cultural issues, and the person-centered care easier to understand. And we are now open for the audience to ask questions. 现在我们的听众欢迎你们提问，请你们用那个 Q&A 这个功能来提问，可以打字在里面，我可以帮你们翻译，中英文都可以。You are welcome to use English and Chinese to ask questions. And Bianca is an expert in cross-cultural care in dementia care. So it's a wonderful opportunity for you to ask questions. Bianca 教授是我们那个跨文化护理的专家。今天我们在这个 web 里面的听众，如果你们有任何问题有关文化方面的，在 dementia care 里面，在失智症跨文化的护理里面的有关问题，都可以问他。欢迎你们提问。Okay, while we are waiting for the audience to ask questions, and can I ask one question? Okay, thank you. I know you said it's free, for the audience and for people to access the moving picture and the wonderful resources as well. And I had a look before your presentation as well. And I know you have had your next project built upon this project. Can you please briefly introduce your next project? Thanks.
Are you talking about the draw care study, Lily?
Yeah.
Okay. So the draw care study is linked to the WHO eye support. And is very similar to the work that you are doing. In fact, you're on the project, so we're very happy to have you participate with us. What we will do with that project is we will take the WHO eye support light posters, and there are 6 posters, and we will animate them to make it very easy, and we'll put on the website and put a chatbot to help people navigate to those portions of the website to find information in their language. These animations will be culturally adapted and voiced over in 9 different languages plus English. These 9 languages are Mandarin, Cantonese, Tamil, Hindi, Arabic, Vietnamese, Spanish, Greek, and Italian. We've picked these languages because they are the top 10 languages that are spoken by older Australians from an ethnic background who are over 65.
Thank you, Bianca. I've got 2 questions now from the audience. The first one, and I don't know the audience, the name and which place the audience is come from, but I just is written in Chinese. I just interpret for you. And you talk about the cultural conflict, and based on your experience, what's the most difficult problem or issues to deal with?
Well, the most difficult problems can often sometimes be when the person has always had this prejudice. And so, they've just had their whole lives, they've never said it, but the dementia has loosened their inhibitions and now they are saying it. And it can be very difficult to overcome that, particularly if it's prejudice to do with skin color, or a belief that a person is lesser because of their ethnic background. So that's the hardest.
Thank you, Bianca. Yeah, that reminds me about the cultural community as well. So if we are working with someone from the cultural background, which is viewed below our culture background or something, we actually need to empower someone to communicate with us, or we need to lower ourselves or disempower ourselves in order to get to know their needs. So the second question is from Anna. I just read through it in English. Fantastic presentation. The video was great. How willing will people to share their personal story about dementia?
It was not easy, I will say that. We worked very hard to recruit and encourage different Chinese families to share their stories with us. Some refused. They did not want to come on the camera and they did not want to be recorded and to tell it. But others understood the importance of a program like this, of a project like this, because they realized that it could help other families who were in the same situation overcome some of those barriers. And they did not want others to go through what they themselves had experienced. They wanted it to be a little easier. And that's why they focused on telling their own stories in that journey.
Thank you, Bianca. The next question is in English. I just read through from Amy. Thank you for your excellent presentation. Is there any good measures for nurses to cope with the conflicts from the diverse cultures in clinical practice? Thank you.
So I believe that it's very important for staff, nursing staff, any health workers and staff to be able to undertake their work safely and without being abused. So I think that's the first point. But like I said, when you have cultural conflict, it's not always easy. And it's difficult to deliver good quality clinical care when someone is being really quite horrible and nasty to you on a consistent basis. So I don't know if there's necessarily a gold standard per se, but I would suggest ways for you for staff to cope with this is to let the organization know, to let your supervisors know, because there might be steps that can be taken to communicate with the family, to communicate with the person, to find ways to manage that conflict. Sometimes it might just be about changing the time that you deliver the care. For a person with dementia, then maybe people get a bit more aggressive in the evening, it's late, they're tired. Maybe you do it in the morning instead, the care. Sometimes it might be that an activity does not really need to happen at that time. There might be an undisclosed or undiagnosed issue around pain that the person is experiencing that is making them be aggressive or have a conflict. But sometimes also people are just nasty. They're not nice. And, there is a question there of really having to eventually say to a family where they are very rude and very nasty to the staff, that is not appropriate behavior. And if that can't stop, then maybe the service has to change or withdraw to some extent, because it's not safe for the staff and it's not fair to the staff for them to be treated like that.
Thank you, Bianca. The next question is from Associate Professor Jing Wang from Xi'an Jiaotong University. Excellent presentation. When culturally adapt dementia care services interventions, what points do you think important. Thank you. So that means when we adapt culturally appropriate, perhaps culturally appropriate interventions from another culture. So what point do you think are very important? Thank you.
Yeah. The first and most important thing I would say is that language or translation is only the start, not the end point. We often think that, oh, if we just take it from, most often it's in English, we just take it from English and translate it into simplified Chinese or traditional Chinese, then that will be enough. No, that's the starting point, not the finish point. The next thing I would say is the adaptation. What we need to understand is local context and what's actually available on the ground. You would have seen in the pictures in the video that we recommended you contact Dementia Australia. Well, you may not have Dementia Australia in China, for example, and it's a completely irrelevant source to be making a referral to. So you have to understand the local context, the local systems, and what's available there. We also have to adapt for appropriate use of language and metaphors and understanding. For example, in English in the UK, there is a very big push around dementia language guidelines that we should not refer to people with dementia as children or as childlike. But in many CALD communities that I work with, people will often refer to people with dementia as in a childlike capacity, right? This person is now like my child. You know, I could see, the lady in the video says, I could see how my mother's fear deepened and my love for her deepened. And, you know, she is like my child, I'm looking after her. So we need to understand those cultural bonds and I guess existing frameworks that are there when we are adapting, so we don't lose those strengths that are inherent within every community and culture. So those are some of the things I'd say we must do when we adapt.
Thank you, Bianca. The next question is from Shannon Chiu from Kaiwu Nursing College of Macau. I just read through her question. Is there any tools, steps for us to deal with culture differences in dementia promotion, health and education? Thank you.
Yes. So Lily, you're probably even better placed to answer this question than me. The WHO has put out very good guidelines on how we might culturally adapt any kind of resources, including dementia ones. And so I suppose the first step is really to refer you to those guidelines and to look at the process that or steps that might be taken to culturally adapt. The most important point I would make there, though, is before you disseminate any information at scale, it's really critical to test it with family members, services, and end users themselves to make sure that you've got the messaging right. We may think we are all from a similar culture to the one we're adapting to, but remember, by virtue of our education, our exposure in healthcare, the degrees we've got, the alphabets behind our names, all of those things might lean us towards sometimes using very technical language, more complex language than families necessarily understand and accept. So it's very important at the end of the day to always work with the end user.
Thank you, Bianca. The next question is from Rin. I just read through how to make sure that what we provide, the care that are the patients want, but not what the health and care system require us to do. Perhaps just go through the first part of the question. Thank you, Bianca.
Yeah, this is I guess the challenge with person-centered care, but also we have in Australia a concept called dignity of risk. Where as healthcare workers, we might want to do everything for the person who with dementia. We might want to almost wrap them up in cotton wool in some respects and look after them, but that may not be what they want, and that may not be what their family wants for them. And so there's a very fine balance there where we must respect the wishes of people with dementia, and we must give them enough, empower them enough to do the activities that give them meaning, but also obviously keep them safe to an extent. You're not going to, let someone undertake very risky behavior like, go bungee jumping from the, 50th floor or something like that. But there has to be scope to allow people to do things that are meaningful for them, to give them that quality of life and a little bit of dignity in terms of risk.
Thank you, Bianca. And because the time, and we have to stop now. And I see a number of the questions from the Q&A, and I'm going to collect those questions and send it to you, Bianca. Hopefully you respond to those questions, and we can return those answers to our audience in the next time. Thank you, Bianca, again for your wonderful presentation and your interactions with our audience. And thank you for our audience for your participation. We will have more webinars throughout the project. The next one is scheduled on 11th November 2021 on the topic dementia care policies and practices in mainland of China by Professor Huali Wang from Peking University. We will send information to you and invite you to attend the next webinar. Thank you all and see you next time. Thank you. Bye.